We'll have an opportunity to ask questions, as I said at the end, so be jotting down your thoughts. And our last speaker is Dan Herman, who's a professor and associate dean for scholarship and research at the Silberman School of Social Work at Hunter College. And he's going to be right here in his home base. And he's going to be talking on a slightly broader scale now, using implementation research as the frame.
Thank you. Thanks, and I know President Raab officially welcomed you early this morning, but I can re-welcome you this afternoon as someone who actually here in the building at the school. So I guess I'm going to talk from the perspective of someone who started out as a social worker, working, kind of on the street and in social service agencies on the problem of homelessness, and specifically on the intersection between mental illness and homelessness, and then became a researcher, and then has become kind of a reluctant disseminator and scaler-upper. Probably not a model of success, but I think probably a model that is a common kind of reflects some common challenges that we find in the field of social work that I think are also common to healthcare services, around the challenge of trying to identify, or once effective models of service have been identified, or intervention models have been identified, thinking about how those can actually be more broadly deployed by people who work in the field. So I know that the general agenda here is on population health and population level interventions, and certainly the talk we just heard about the 100,000 Homes campaign is, as I understand it, like a population level approach to try to deal with the problem of homelessness. So the work that we've done is sort of, if you could drill it down a little bit and think of it as where this model belongs, as sort of within, potentially applied within a campaign like the 100,000 Homes campaign, but on the street with people who are direct service providers, with people who are homeless or people who are at risk of homelessness. So I'll just briefly tell you what that is, just so it makes sense to you, and then let's see if I can go forward. But I don't know where our PowerPoint are, but I can do it with that. You can get it on. So the work that we did really began, someone was earlier saying how long things take. So, I mean, this work began in the 1990s when I was a young man, actually, and so our colleagues were younger. Herman. Thanks. So this is a picture that is very hard to make out, but this is a picture of the Fort Washington Armory, which was a large shelter for homeless people, homeless men actually, in New York City in the 1990s. And you can't really tell, but this is like a gigantic drill floor, maybe about the size of a football field, and these are all beds set up. There were probably 1,000 or 1,400 people, and there were a bunch of shelters like this. So this is back in ancient history. These don't exist anymore, but the problem obviously still exists, even though significant progress has been made. So basically what our experience was here was trying to identify people in this large population of homeless people who needed special kinds of help, who need medical care, psychiatric care, and obviously they needed housing. Over time, as housing became available in the city through the development of a variety of new programs that provide supportive housing for people, some people went into those housing units, some people were able to be reunited with family members, some people were able to find rooms on their own. So social service staff did a lot of that work with people, and it's hard work. What we found was, unfortunately, for many people, their retention in housing did not always hold, and people often cycled back into the shelters, or they ended up back in other institutions and that kind of thing. So that was kind of the beginning of the model. that evolved there. And it was basically, so this is a model that evolves up from street-level workers saying, well, how can we do what we're doing better? And so, so CTI, critical time intervention, is basically just a model of how to provide support during high-risk transition periods, with the idea that if you can do that effectively, that people's long-term outcomes and their long-term trajectory will be better. So it's a pretty simple-minded idea, but the thing that I think differs in terms of, and people will recognize this as sort of a case management model. In other words, a worker connected with a service recipient, client, trying to help them navigate through a complex system or environment with a lot of fragmented services and a lot of roadblocks. So that's what CTI is. It's a little different. It is different from sort of traditional case management, or what people often now call care coordination models, in that it was seen explicitly to be time limited and just attached during periods of transition that had been identified through research actually as being high-risk periods. High risk for recurrent homelessness, high risk for rehospitalization, incarceration, a variety of health risks. So CTI was like overlaid at this transition point. CTI workers were taught as a bunch of skills and a model to apply that helped them focus on individual level risk factors for homelessness, recurrent homelessness. And the model is applied in essentially 3 phases over 9 months of decreasing intensity of involvement with the person. So the idea here is that a sort of thoughtful way of providing transitional support that aims to link people to long-term supports in the community could potentially have the capacity to help people get more effectively rooted in the community, so as to reduce the risk of recurrent homelessness. So that's the simple-minded idea, you know, and it was tried out in a number of shelters. And then we were also fortunate enough to get funding from NIH, National Institute of Mental Health, actually, to do a randomized trial where we actually, you know, randomly assigned people to get CTI for 9 months, or to get sort of normal discharge planning and follow-up services that were available in the system. 9-month intervention, 18-month follow-up. So essentially we followed people during the course of the intervention, but we also followed them afterwards to see if the sort of logic that we had, which was that the time-limited intervention would have an enduring impact, could be supported. So in a study in the shelter system, we found, you know, about a 60% reduction in the risk of recurrent homelessness. We were able to get funded again by NIMH to adapt and use the model with similar population of homeless people being discharged from psychiatric hospital, which, as we know, is another key risk period for homelessness. We did a very similar design study in a state hospital system, and again we were able to show like pretty strong results in terms of reduced risk of homelessness, as well, in fact, as reduced risk of psychiatric rehospitalization, which goes to someone's argument perhaps that that retention of housing can be a form of, or at least can be related to health outcomes directly. And so here we go. You know, we have this pretty well described approach. We have pretty strong evidence from randomized trials. You know, so what do we do with this? Well, you know, if you're an academic, you publish articles in the professional literature. We certainly did that. You know, and then what ended up happening was we started to get contacted occasionally by, you know, service providers saying, well, this is an interesting model. How can we use this? You know, and the challenge here, of course, and I think this is probably played out in academic disciplines, certainly in social work, I'm sure, in healthcare, is then, well, how do you then help to influence the field, which is what we were interested in. My view from the outside in terms of how the government looks at this is, well, we will establish lists of effective interventions. We'll have a national registry of evidence-based policies and programs, or more recently, the Coalition for Evidence-Based Policy has a more rigorous set of standards for what's considered an effective model. We'll put them on a list and we'll put them on a website, and and then that's what we'll do, and then we'll hope that the organizations take this up. And in fact, with SAMHSA in the United States now, this model for any RFPs and funding announcements they issue related to homelessness, if you read the fine print, you will see Housing First model and you'll see CTI as evidence-based models that providers should be including in their applications. So, my issue is that, and I think all of you in this room, if you're interested in this topic, I'm sure you will agree that is not really going to be an effective model leading to scale up. So, we sort of followed that, and we followed that approach, or we've played along with that approach, let's put it that way, but then realized that that's not really enough. We don't really have the capacity, and I think most intervention developers don't have the capacity themselves to do what's needed to be done to move it along. So what we've done is essentially a partnership strategy. We've identified organizations whose business it is essentially to train, training organizations. We've worked with organizations that are nonprofit trainers. We've linked up with some for-profit organizations whose business it is to train providers. We've tried to connect with advocacy groups who are advocating for particular service models on a national level, as well as policymakers. So we've connected with the VA, which obviously has had major programs around homelessness reduction. And now we're also trying to start more of an effort here at the school to be able to support this. And when we've launched a center to try to help sort of spearhead this. I mean, I guess I would just close, and I guess we'll have a conversation about this after. In addition to, my rant about sort of an inadequate infrastructure for support for uptake of evidence-based models, at least in the field of social services, and I suspect in healthcare as well. I think that, the thing that one of our major concerns here is really how any of these dissemination efforts are able to be sustained. I mean, I heard some interesting ideas about and thoughts about how these can be linked with commercial enterprises. Sadly, I don't think this kind of model is something that's going to be a big seller in terms of a moneymaker. But what are the models that can be used to develop an infrastructure and sustain an infrastructure that can help promote effective dissemination? And then I think the other issue for me is that models like this, especially in the world of social work, to be effective, and I think this is one of the great things about the 100,000 Homes campaign, needs to be locally relevant. In other words, approaches need to be adapted to fit the unique needs of communities. When you're trying to promote some kind of evidence-based model that is community-based, there's a significant challenge from my point of view as to how you allow for helpful adaptation to a model at the same time as keeping some of the fundamental elements that account for its impact. And that's something that could be considered an implementation research question. It's not something that I think has a clear answer. So I'm hoping that means that lunch is here, but I'll let our chair announce.
Thanks, Dan. Thank you very much to the entire panel.